Hello, my name is Laura Simko, and I am presenting a study investigating length of stay for mental health patients in U.S. emergency departments. I would like to thank my co-authors, specifically thank you Dr. Wong for being a great mentor, and Elizabeth for spending countless hours teaching me the ways of Tableau. I would also like to thank the Stanford University Med Scholars Program for funding this project. I have no further disclosures. So first, let's start with some background. Deficient resources for mental health patients makes finding care difficult. Due to this lack of access, mental health patients may put off seeking care and ultimately, when in crisis, go to the emergency department. While in the ED, mental health patients experience some of the longest lengths of stay, which is detrimental to their health and may even exacerbate their mental health crisis. The prolonged lengths of stay experienced by mental health patients ultimately leads to a cascade of negative effects, including overcrowding. These effects have implications for all ED patients. For this study, we used the Center for Health Statistics National Hospital Ambulatory Medical Care Survey. Data was drawn from years 2009 through 2015 for patients between the ages of 18 and 64. NHAMSES is an annual survey resulting in a national sample of ambulatory care visits within the U.S. In order to obtain national estimates, data was weighted in accordance with NHAMSES data file documentation. For the analysis, we broke the dataset up into multiple comparison groups, which I will describe in a couple slides. This was done using ICD-9 codes and external cause of injury codes, also known as E-codes. The primary outcome was ED length of stay. During preliminary analysis, we determined that there was significant variability in length of stay, demonstrated by a very large spread of mental health visit length. Because of this, we also used benchmarks of 6 and 12 hours in subsequent analysis. In addition to length of stay, we investigated differences in discharge practices across comparison groups because we suspected a strong association between ED disposition and length of stay. The first comparisons we made were between mental health and medical visits. After this, we took a deeper dive into the mental health group and compared visits for psychiatric versus substance use versus dual diagnoses. The dual diagnoses group comprised visits which had both psychiatric and substance use ICD-9 codes associated. In our final comparison, we compared medical versus mental health visits across 4 regions of the United States as defined by the U.S. Census. First, I will present our findings from the mental health versus medical visits comparison. Of an estimated 555 million ED visits over 7 years, 5% were mental health and 95% were medical. ED visits for mental health disorders were more likely to be by patients that were male and white. They were also more likely to have public insurance and be experiencing homelessness. This graph is a little bit complicated, but I'll walk you through it. Mental health is on the left and medical is on the right. Length of time is on the y-axis and disposition is along the x-axis. The median and interquartile range for mental health and medical visits are plotted by disposition, with the width of each line representing the proportion of the mental health and medical groups resulting in each disposition. Here we see, of the mental health visits, 16% resulted in admission and 13% resulted in transfer. There were fewer admissions and transfers following medical visits. Mental health visits also seem to be longer regardless of disposition, with mental health visits resulting in transfer having the longest length of stay and medical visits resulting in discharge having the shortest length of stay. Because of the significant spread we see in length of stay, our next set of analysis makes these comparisons using benchmarks of 6 and 12 hours. So here in adjusted analysis, using the benchmarks, we are comparing mental health to medical visits. We see that mental health visits were longer than medical visits overall, specifically 2.2 times more likely to last over 12 hours. Mental health visits resulting in transfer or discharge were the biggest contributors to this difference, while mental health versus medical visits resulting in admission had similar odds of lasting over 6 hours. Notably, mental health versus medical visits resulting in transfer were 3 times more likely to last over 6 hours and 2.7 times more likely to last over 12 hours. These findings of increased length of stay for mental health visits, and especially for those needing transfer, prompted us to investigate possible associations between length of stay and several mental health subgroups. We wanted to see which types of mental health visits were most susceptible to longer lengths of stay. We divided the mental health group into 3 categories. Psychiatric visits made up the majority of visits, followed by substance use, then dual diagnoses. The psychiatric diagnosis visits were by patients that were younger, more likely to be female, and have Medicare insurance. The substance use diagnosis visits were by patients that were older, were more likely to be male, self-pay, and be experiencing homelessness. The demographics of the dual diagnosis group were not significantly different from the other two groups, but rather fell within the spectrum set by the other two groups. Race ethnicity was similar across all three groups. This graph shows the breakdown of dispositions. Transfer is on the left in the darkest blue, admit is the medium blue on the right, and discharge is in the center. Disposition patterns for the three groups were varied. Dual diagnosis-related visits were the most likely to result in admission or transfer, and substance use-related visits were the most likely to result in discharge. This graph has the same format that we saw before. The main takeaway here is that dual diagnoses visits had the longest length of stay, regardless of disposition. This table shows the odds of a visit lasting over 6 or over 12 hours for each mental health group compared to the medical group. Similar to what we saw in the unadjusted data, dual diagnoses visits continue to have the longest lengths of stay overall. Focusing in on disposition, we again see that mental health visits requiring transfer had greater odds of lasting over 6 and 12 hours. Furthermore, the odds for psychiatric and dual diagnosis visits were higher than those for substance use. However, for discharges, substance use visits were almost 4 times more likely to last over 6 hours and 2.3 times more likely to last over 12 hours. Dual diagnosis visits were even more likely to be longer than our benchmarks. They were 4.7 times more likely to last over 6 hours and 2.8 times more likely to last over 12 hours. In our final analysis, we wanted to dig into the significant variation we saw in mental health visit length of stay. We wanted to see if this was a regional finding or something consistent across the U.S. When comparing the mental health populations of the 4 regions, the Northeast, Midwest, and West had visits by mostly male patients. The Northeast had the most public insurance visits, and the South had the least. The West and Northeast had the most visits by patients experiencing homelessness. In this figure comparing disposition patterns for mental health versus medical visits by region, we saw that medical visit dispositions were similar across all 4 regions. Approximately 89 to 90% were discharged, 8 to 10% were admitted, and 1 to 2% were transferred. But when we look at mental health visits, we see a lot more variation. The Midwest discharged the least, while the West discharged the most. The difference between the two was 13%. But the Northeast and Midwest were more likely to admit than transfer, while the South was equally likely to admit versus transfer. Moving on, this graph is similar to the ones we saw before, but has a lot more in it. First, let's focus on the medical visits. We see relatively consistent lengths of stay across regions. But when we look at mental health visits, we see more variability. Finally, moving on to adjusted regional analysis, we can see that overall, mental health visits in the Northeast were the most likely to be extended. For visits resulting in admission, mental health visits were not more likely to be extended than medical visits. But for visits resulting in transfer or discharge in any region, mental health visits were more likely to last over 6 hours and 12 hours. Though, the odds were varied across the country. Notably, in the Northeast, mental health visits were 5.2 times more likely to last over 6 hours and 3.3 times more likely to last over 12 hours. These are odds higher than those seen in any of the other 3 regions. So in summary, we found that mental health visits continue to be longer and are especially long for visits resulting in transfer or for patients with dual diagnoses. Regionally, there is significantly more variation in disposition patterns for mental health visits compared to medical visits, but extended ED length of stay for mental health patients is a nationwide problem. Efforts dedicated to decreasing ED length of stay for mental health patients would not only improve the care for this vulnerable group, but would also have subsequent positive effects for all ED patients. Finally, the significant variations seen in mental health visit length of stay and disposition indicate that there is a need for a standardized system for managing mental health emergencies in the United States. Thank you for your time, and feel free to contact me with any questions.